Welcome everybody. We're going to allow 20 or 30 seconds or so for people to come online. I should be able to accommodate them. I saw something this morning that the interview between Elon Musk and Donald Trump, there were 8 million people who tried to get on, and obviously they couldn't all do that. Not quite expecting 8 million, but we will allow a little bit of time for you all to log on and in. By watching a proverbial kettle to boil. Okay, look, we might get underway. There'll probably be some more people join as we go. So again, welcome to everybody. My name's Dr. Joe Kosterich. I'm a GP and medical consultant at Little Green Pharma. We'll put up disclaimers in a moment. And this is Medicinal Cannabis, a crash course. I'll be co-presenting with Barb Fullerton, who's the head of education at Little Green Pharma. So first up, as I mentioned, I am a medical consultant to the company. I've been so for 7 years. It is a paid position, pays enough to keep me in general practice. An entity of which I'm a beneficiary has also bought shares in Little Green Pharma. You can see some of the other positions I hold there as well, none of which are immediately relevant, but keeps the lawyers happy. Okay, so today we're going to cover medical cannabis, an overview, evidence and usages, how to prescribe. There are a couple of tweaks to it that are a bit different to writing out a prescription, say, for amoxicillin, but it's also still relatively straightforward once you've got your head around the basics. We have a couple of case studies, how Little Green Pharma can help, and we'll allow some time for questions and answers at the end. But first up, as we always do, take the pulse of the room, or the temperature of the room, whichever term you like, with a quick poll to find out where you're all variably at. You can see the questions on the screen there. Are you already prescribing medicinal cannabis, yes or no? And if so, then down below you can see what's your level of familiarity. A general interest, I've written a few scripts, I'm a regular prescriber, and this is looking as it typically does. That most of you, allow another 10 or 15 seconds or so, most of you have not prescribed or have written only a handful of scripts. That's pretty much typically what we get. And that's exactly as it should be. If you've been prescribing for 5 years and you know it all inside and out, then welcome along and thanks for chiming in. But typically this is for an audience that's wanting to learn a little bit more. So again, thanks for your time and investing that in the webinar tonight. And certainly by the end of it, you're not going to know everything. Nobody knows everything, but you'll know enough to make a start if you're wanting to go down that path. All right, so we'll end that. Let's close that. Thank you. Oh, what's happened there? Put some button. Can you see the? Oh, I lost. Oh, there we go. What's happened there? All right, sorry about that. The joys of technology. At least it's not. Was it cloud space, or was it one that went belly up the other week? At least we've recovered quicker than that. So it's all new. Medicinal cannabis is new. Of course it is, except it isn't. It was used in almost all human societies that work's been done studying it through to the early part of the 20th century. Forerunners of what is today Pfizer and Eli Lilly, amongst others, had medicinal cannabis products that they manufactured. They were prescribed by doctors, dispensed by pharmacists, taken by patients for conditions along similar lines to what we use today, and that includes insomnia, neurological symptoms, chronic pain, insomnia and anxiety. And then in the 1920s and 30s, something changed. This next slide is possibly a little bit confronting, but I think it's just really important. If we don't understand history, then we tend to make the same mistakes. So most people have heard of J. Edgar Hoover, the first head of the FBI, a position he held for close to 40 years. A contemporary of his was Harry J. Anslinger, that most people, and I include myself in this before I got interested in this area, had not heard of. He was the first commissioner for the Federal Bureau of Narcotics, the forerunner of what is today is the DEA, or Drug Enforcement Agency. Anslinger was a prohibitionist. Prohibition of alcohol in the United States was coming to an end in the early 1930s. If you're a prohibitionist and you're sort of going to be out of work because nothing's being prohibited, what's a good solution? Find something else to prohibit, and cannabis was it. And Anslinger pushed for the introduction of the Marijuana Tax Act of 1937. He argued very vociferously and strongly. I gather he was quite a forceful personality, as some of these characters tend to be, that cannabis was dangerous for a variety of reasons, mainly to do with race relations. His proposal to ban it was opposed by the pharmacy lobby at the time, by the American Medical Association and others. Anslinger won the day, and the rest, as they say, is history. And then people forget. And when it's come back around, we sort of think it's all new. And also we tend to believe what we've been told over the years, a lot of which essentially is mythology constructed by Anslinger and some of his disciples, including members of the Nixon administration. So in 1964, Raphael McCollum isolated THC for the first time. He's regarded as the father, if you like, of medicinal cannabis. He passed away last year, he was in his 90s. First used in Israel medicinally in the 90s. In 1996, the first US state legalized medicinal cannabis. It's now legal in some way, shape or form in almost every state and territory in the United States. And that ranges from CBD only right the way through to adult recreational. I don't like the term, but it's one that's used recreational use in about 24 or 25 states. And each year, and there's obviously going to be an election coming up in a few months, each year when we hear about the presidential election and Congress, we don't hear about the various referendums or propositions, as they call them in America, that are put up in different states. Pretty much every time a proposition is put up to legalize cannabis, it gets approved. And there may well be a few more by the end of this year. Canada in 2001, Australia, UK, New Zealand, also Germany, Czech Republic, Thailand. The list does go on. France is currently in a pilot, and it will go legal next year with medicinal cannabis. So in a period of time, the next decade or so, we'll probably be back where we were 100 years ago. Cannabis is not a single patented molecule. It comes from a plant. And it has a lot of bioactive, a lot of molecules, like an apple or an orange or a grapefruit. There are cannabinoids. The main ones are CBD or cannabidiol and THC, tetrahydrocannabinol, delta-9 THC for those who want to be purists. You've got the acidic forms, which have an extra carboxyl unit for those who remember their organic chemistry. That gets liberated at 60 degrees centigrade. CBG, CBN, there are other minor cannabinoids. In addition, there are flavonoids, which are antioxidants, and all of this is also found in green tea and berries. Terpenes, which provide aromas, and there's a number of those, and they may also have some therapeutic benefits, but it's not really been anywhere near as well studied, so it's not a basis for prescription. CBD and THC really are the basis for prescribing. And the concept of the entourage effect is that the total is greater than the sum of the parts. And some of these minor cannabinoids, some of the terpenes and flavonoids, we may not understand exactly what they do, but they're doing something and they're supporting the two main cannabinoids. And that's the argument in favor of whole plant extract. There's also a role for isolates, but the idea of the whole plant extract is that you are getting this entourage effect. The human body has its own endocannabinoid system. This was discovered in the 1990s, again by McCollum. Has a number of functions, and including but not limited to pain, appetite and digestion, sleep-wake cycle, mood and mental health, and inflammation. Which, when we see the role and where we use medicinal cannabis, it makes a lot of sense that if this is what the body's own endocannabinoids, and the body produces two of them, 2-AG and anandamide, there might be some others as well, but they're the two main ones described. So a whole system of endocannabinoids, receptors, enzymes that break it down. Like all body systems, it can get out of balance, and that may in turn contribute to the symptoms that we see. And you can see the receptors for CB1 and CB2 spaced pretty much through the entire body. So cannabis is not an anti-drug. It's not like we have antibiotics, we have antihypertensive, we have antidepressants, we have anti-inflammatories. They're working against something. Cannabis is working with the body. It's working through the endocannabinoid system. It's not an anti-drug. Then there's nothing wrong with any of those medications. They have a role. This whole concept of the use of medicinal cannabis is more a restoration of balance. My personal little hobby horse, this argument that there are there's no evidence. There is evidence. In fact, I think next time we'll need to update this slide. I think there's more than 4,000 papers now. In fact, I think it's probably over 10,000 if you go into PubMed. And the Society for Cannabis Clinicians, the Canadian site, they're probably also nudging 1,000 or so. And you can sign up for emails from the cannabisclinicians.org. New research is coming out and being published on a fairly frequent basis. So there's lots of evidence out there. People want to argue about the merits of individual studies. We can do that, but that's a separate argument to saying that there isn't evidence. And there's that wonderful place called the Real World. Locally in Australia, the Quest initiative, which was done by the University of Sydney, supported by LGP, but done by the University of Sydney, a study of over 2,300 people. The 3 months data shows improvements in anxiety, pain, depression, fatigue, and sleep. Not surprising. The 12 months data should be published sometime in the next few months or so. And Barb will touch on this. Quest version 2 is currently underway. So showing, and keeping in mind that the people who are in this trial are those who have failed other treatments. If, and it isn't, but if it was first line, we might see even greater improvements than this. There's another study that was done by LGP, and this is looking at the balanced or 10-10 formulation in chronic pain. Once again, treating people who'd failed virtually everything else, and there's lots of medications, injections, physical therapy, surgery, etc. It's, like a lot of stuff, a lot of treatments. And nearly half of those experienced improvement in pain impact scores and also improvements in sleep. Now, you might look at that and say, well, that's only half. But this is half of a very select population who have got no response to virtually anything else that they've been on before. That's actually, and if you go to those people and say, look, you've got a 50-50 chance of some improvement, a lot of them will say, I'll take that. I'll take those odds. It's from the American government, again, just more evidence of evidence. And from the Cochrane collaboration, all cannabis-based medicines pulled together were better than placebo in reducing pain intensity, sleep problems, and psychological distress. Now, this is the hurdle that any medication typically needs to jump over to get approval and get usage, is that it's better than placebo. And better than placebo, again, in clinical studies. So that's the opinion of maybe not opinion, that's not the right word. That's what the Cochrane collaboration found by crunching all the data, which is what it does. Now, by comparison, pregabalin has a role, I'm not saying it doesn't. Very limited evidence for neuropathic back pain, cancer pain, or other forms of neuropathic pain. Now, the same people, and I'm talking about you, pain faculty, who are very happy to recommend pregabalin because apparently there's lots of evidence. They don't think there's evidence for medicinal cannabis. Well, there is. The TGA also has a view. It feels that there's evidence and it's produced its own documents for multiple sclerosis, palliative care, epilepsy, nausea and vomiting, and chronic non-cancer pain. You can download that from the TGA website. The MJA Insight, which is an AMA publication. Again, the AMA has not been a particular fan of medicinal cannabis, but they've also needed to concede, if you like, that there's reasonably well established efficacy for CBD and anxiety, psychosis, pediatric epilepsy, for THC in chronic pain, chemo-induced nausea and vomiting, spasticity, and emerging evidence in these other areas. And as mentioned before, there's more papers being published on a very regular basis. And as more jurisdictions legalize medicinal cannabis, it's easier to do the studies. It was pretty difficult previously to do lots of studies on a product that was actually illegal. There is overlapping effects from CBD and THC. And as we saw before, the concept of the entourage effect is also that they can work better together and synergistically. So they both have an analgesic effect. I won't read all of these out. You can see them on the screen. They both have an antiemetic effect. They both help with sleep. They can both stimulate appetite. THC can be intoxicating. You have enough of it, and again, this is not in a medicinal form or a medicinal dose, but if you want to take too much of it, then yes, you can get high and you can feel all the effects thereof. CBD does not have psychoactive effects. You will not get high, doesn't matter how much you take. And it also can reduce or offset some of the intoxicating effects of THC. But I really want to emphasize that in a medicinal dose, it's not any more of an issue than with the use of other pain meds, including opiates, the atypical opiates, tramadol, and a whole lot of medications that we use for anxiety and depression, which can also have some of those side effects. It's not a dangerous substance. If we look at this ratios here, alcohol 1 to 10 is essentially saying if a few drinks, again, not entering into the rights or wrongs or drink safe limits with any of this, but if a few drinks has, in inverted commas, the desired effect, 10 times that amount can be fatal. With codeine 1 to 20, so you've got enough codeine to ease your pain, 20 times that amount can be fatal. Caffeine 1 to 50, cannabis 1 to 20,000. Estimated you have to consume about 20 or 25 kilograms of cannabis for a lethal overdose. Now, that traces that THC might be found in toxicology when particularly celebrities overdose. Yes, that is the case, but that's not what's killed them. We also hear that it's this highly addictive substance. Weight for weight, you see cannabis 0.8, caffeine 0.9, alcohol 1.6, tobacco 1.8. It's not saying that you can't be physically addicted to it. You can, especially if you use too much too often. But on a weight for weight basis, and this was published, I think, in The Lancet some years ago, less addictive than a lot of other substances that are in common use. As everything else does, it has side effects. Drowsiness can be one, particularly with THC. Dizziness for some people. Dry mouth, that's fairly common. Anxiety, not so much, I don't think. Diarrhea or loose bowels, I wouldn't say it's rare. I'd say loose bowels is not uncommon. And in an elderly age group, sometimes, particularly if they've been on opiates, they see that as a plus rather than a minus. And fatigue can also be a plus if people take it at night and they've had problems sleeping. But as with any medication, if side effects outweigh beneficial effects, then you need to reconsider and possibly stop. And the more we can think about medicinal cannabis in the same way that we think about every other medication, the more we've simplified our life. How do we look at any other medication? What are the benefits? Is it applicable? Is there an indication? What dose do we want? Are there side effects? Do we need to manage those? Exactly the same. And there are drug interactions with the cannabis, as with every other medication. In practice, certainly in my experience, and also speaking to colleagues who've been prescribing for a while, in practice, it's typically not a major issue. You may want to start at a lower dose. People are on warfarin and check their INR, as you do with any other medication. And some of the NOACs, you might also want to start on a lower dose. There might be some potentiation. PPIs, not really seen any particular problems with those. But in an older age group, or if there are concerns, you can always start at a slightly lower dose. Some of these medications probably not that frequently prescribed. Theophylline is also not something we see prescribed that much these days. And there are contraindications and precautions, same as every medication. If you're allergic to it, like penicillin, if you're allergic to penicillin, you don't prescribe it. If you're allergic to cannabis, I've personally never seen it, but sure it can happen, you don't do it. Pregnancy or breastfeeding also. For THC, unstable cardiovascular disease. Now, if you've had a heart attack last week, this is not the week to start the patient on medicinal cannabis. If they've got stable cardiovascular disease, and you'll see that in the case study, it can be used quite happily. And the reason for this is it may lead to tachycardia. Again, it's a dose-related issue. Active mood disorder or psychosis would also be a strong precaution with THC, and in those situations you probably want to liaise with the treating psychiatrist. If somebody has had an acute episode 10 years ago and no problem since, again, that's probably not going to be an issue or a problem. And anxiety, you're generally going to want to use CBD and not THC anyway. TGA has said, and they said this publicly, that they approved treatment for over 215 conditions. Fair to say that a lot of these conditions cause similar symptoms such as pain, sleep disturbance, psychological issues, palliative care. So, yeah, the indications remain chronic pain, anxiety, nausea and vomit, MS, etc. Roughly 60-40 in favour of men, so seem to be a few more males than females looking for or being treated with medicinal cannabis. Chronic pain, about 53%. If we bundle together sleep and psychological, we're getting towards 40%. And a lot of the people with chronic pain also have problems with sleep. Keeping in mind, these are from SASB applications, and typically doctors will put in one reason, even though there might be two or three. Over 558,000 approvals as of 22 July, and that's been growing quite steadily. Now, the first question people might see looking at this chart, why does it seem to have plateaued after 2021? That's because there was a change in approval process. Previously, before November 2021, every time you changed formulation, you needed a new approval. Now, if you are within the same category, and we'll go through those, you don't need a new approval. So hence, less actual approvals, not necessarily less people being treated. In fact, the number of people being treated appears to be going upwards. And if we look at these figures for 2024, certainly on track to exceed 2023. Two main forms of medicinal cannabis are inhaled and ingested. So orally, there are oils, capsules, there are more edibles or what are called gummies coming on the market, similar to what's been available in North America. Vaporized, typically dried flower or vape carts. There's roles for all of these, and they can be used in combination. Ingested or orally is going to get into your system a bit more slowly, out a bit more slowly, inhaled the opposite. There are two overarching requirements to be able to prescribe medicinal cannabis in Australia. Number one, a condition where medicinal cannabis may be of benefit and where studies exist. And the TGA has already done this work for you back in 2017, 18. You actually had to send them studies that you'd found yourself 7 years ago. We no longer need to do that. They've got a drop-down menu if somebody has chronic pain. So any of the indications that the TGA accepts where there is evidence, you just put that in, and they've already gathered up the information. And obviously, you're not going to prescribe it where it's not going to be a benefit. I mean, it's a little bit of a, it's a statement of the obvious. I'm going to prescribe a blood pressure medication for high blood pressure if they don't have high blood pressure. Number two, other treatments have failed or caused unacceptable side effects. That isn't first line. But there is no set number which need to have been used, so you don't have to have exhausted every other possible treatment. Believe me, a lot of people have been through quite a lot by the time they come to consider cannabis. And there's no level of side effect that must be reached. So it's an issue of clinical judgment. There are a lot of products. It'll be quite a few more than 450 as we sit here today. With the exception of nabixabols and Epidiolex, they're not ARTG registered products, so they're unregistered products or unapproved products, but you get from the TGA approval to prescribe an unapproved product. Go figure. And I mentioned about the different dosage forms and the categories. Under 2% THC is Schedule 4. Greater than 2% THC is Schedule 8. CBD has actually been down-scheduled to Schedule 3, which means it could be bought over the counter without a prescription. There just aren't any products available as yet. It's non-PBS with the exception of Epidiolex, which is for pediatric epilepsy, Lennox-Gastaut syndrome in particular. When it was put on the PBS, I think then Mr. Hunt said there were about 110 patients in Australia in that boat. A DVA does offer some cover, depends on what card the person is on and obviously the indication, and some insurance companies, including HIF, and Bart will touch on that, may also offer a rebate. Again, it depends on the table and coverage. Dosage, international mantra. This is the international mantra: start low and go slow. You want to get to the lowest effective dose. And this doesn't apply to any medication. We don't want to give people higher dosages of metformin than is necessarily to control their diabetes. You don't want to give people higher dosages of inhaled steroid for their asthma than they need to control their asthma. So the same principle applies with all medications. Now, one can start quite low, 2.5 milligrams of THC. In some instances, a bit lower than that if you wanted to. In some instances, we'll start a little bit higher. And then increase it every few days. Sometimes it's taken just at night, probably twice a day might be the most common, but for people with the cancer symptoms, they might take it 4 or even 5 times a day in smaller divided doses. Very, very personalized medicine. What works best for the individual, not one size fits all. Obviously, we've got to monitor people. Generally best after 1 to 2 weeks, once they've been on it for 1 to 2 weeks. So sometimes it might take people a few days to get their prescription filled. And then after 2 to 4 weeks, and then really as clinically indicated. As with all medications, as people are getting more stable, you don't need to see them quite as frequently. And you want to assess when they come back, how the symptoms are going, they're getting any side effects, do we need to make some changes? Good idea to have annual liver and kidney function. That might be being done in the normal course of events. Cannabis is processed through the liver or metabolized through the liver and excreted through the kidneys. It doesn't damage either of those organ systems, but this needs to be in adequate shape. The three main pathways are SASB, so that's a per patient approval. You put in the individual's details, TGA, one's initials and date of birth, why you're prescribing it. There's authorized prescriber, which is to the doctor rather than per patient. We'll put up examples of each. And rather than on a notification as you go basis, that's a notification every 6 months as to the numbers that you prescribe for. They don't want a list of names. And then the third system is authorised prescriber, established history of use, similar to the authorised prescriber in that there is 6 months reporting, but it doesn't cover all conditions and all categories. But, you know, it's a reasonable mezzanine level for those who perhaps are at SASB and thinking about going down the AP path, which I would not suggest to anybody until you've done at least 20 to 30 scripts and you feel you are going to be doing it more frequently. So SASB application, when you get it back, the first page is standard legalese. The schedule will show the doctor and will have a number. What category has been prescribed at the 5? Again, is it oral or is it inhaled? Patient initials, gender, date of birth and reason, and it'll have an expiry, which is somewhere usually 1 or 2 years. Authorised prescriber, again, there's pages of standard legalese, and then it will outline the category, the indication. It won't have the patient's name on it. It'll have yours, and it'll have they call it an MAP number, which is unique to the individual doctor. And also, you will have a number of MAP numbers. I've got 18 because each different category and each different administration route has its own. Only government could do this, has its own separate authorisation. So the 5 categories, starting from high CBD greater than 98% through to CBD dominant, roughly equal parts, THC dominant and a high THC. And if you're changing formulation, if you've got somebody on 50-50 and you want to put them on 80-20, you will need a new approval. If you've got somebody on 50-50 and you want to put them on a different brand of 50-50 or even 45-55 or 48-52, you don't need a new approval, which is why there was the plateau in approvals. On a script, again, as always, and it'll be in your software, whether it's best practice or medical director or others, product name, active ingredient, your bottle size, your dose, you want to put on number of repeats. You don't have to issue repeats, you can. And if you are, then you might also want to include the number of days between repeats. Pharmacy will need the script and the approval letter, whether it's a SASB or an AP form. And different states and territories have different requirements. In WA for categories 2 to 5, you do need to notify state health. So that's pretty much covers what we've spoken about before. Again, as mentioned, under 2%, so greater than 2%, no, that was right the first time. 98% or more CBD, Schedule 4, so greater than 2% THC is Schedule 8. Approval is prescriber specific. You'll often get approvals to prescribe Schedule 8 medications, and it will say to Dr. X and other doctors at the practice. With medicinal cannabis, it is prescriber specific. They are typically private, although as mentioned before, DVA does cover chronic pain, and it does depend again on what the individual veteran is approved for and their card. Private health we've mentioned. Okay. Can patients drive? Look, we can do a whole webinar on itself. It is discriminatory. Most states, and Tasmania is the exception. If THC is detected in the system, then people may lose their license. This is discriminatory. because the level at which can be detected is way below any level that could cause impairment. And by the way, if you're on opiates or benzodiazepines or a whole host of other medications which could cause significantly more impairment, you waive your prescription and away you go. Different states, I think in South Australia, Western Australia, and Victoria, and Queensland, it's all gone to different upper house or different parliamentary committees to look at this. Nobody's moving particularly quickly. Obviously, there's revenue at stake here. There is a campaign driven or spearheaded by a retired magistrate at drivechangemc.org.au. Brian Walker, who's a GP and an MLC in the upper house in WA, has had tabled an inquiry and is hoping to get some movement, but can't see that happening until, well, certainly won't happen until after the next state election. I can't imagine any movement in Queensland until after their next state election either. Medicinal cannabis is big picture. It's ideally suited in a primary care setting. We're not curing the condition being treated. Now, I've spoken a bit about the knockers who say it doesn't work. At the other end of the spectrum, you've got people who think it's a cure for everything. It is not that either. It is, though. It is very, very much about alleviating symptoms, generally with mild side effects, and improving quality of life. People feel better. They'll come back and say, I feel better. It doesn't work for every single person. But some people will come back and say, well, this has really transformed my life. I'm feeling so much better. Less pain, better sleep, less grumpy. Very, very much big picture. And potential, again, not always, but potential if people have multiple symptoms to reduce polypharmacy. And there's some fair bit of work out of North America showing that something up to 50% or more of people are either able to reduce or stop benzos and opiates when they're treated with medicinal cannabis. So it's not the panacea, but it has a definite role in certain conditions for certain patients. It has an excellent safety profile. It's a lot safer than a lot of other medications that we use in medicine. Efficacy varies, same as every other medication that we use. Quality of life and symptom improvement are the goals. Applications are pretty straightforward. Some people years ago used to get a bit spooked by them. If you've never done one before, the first one will take you longer. Of course it will. You have to set up your TGA account. You haven't done it before. You're taking it a bit more slowly. By the time you're doing your third or fourth, it'll take you 3 minutes or so. And obviously there's help available as well. All right, going okay for time. So how do you choose a product? How do you choose a blood pressure medication? How do you choose a diabetes medication? Again, there's no absolute answers to this, but the beginning is what symptoms are we treating? So again, if we're treating anxiety, we might be going a different path if we're treating pain. So what ratio of THC and CBD are we looking at? Which administration route? And we have got a choice of two. There, in due course, maybe others. Are there any contraindications, precautions, or other medical considerations? Some people aren't going to be suitable for it. People who are registered drug addicts, probably not going to be prescribing a THC product, and certainly not without specialist input and approval from the relevant state health department. Work or driving, are they subject to random workplace drug testing? That might be an issue. Driving, again, if people don't drive, it's simple, and they need to know the laws around this. If you're an Uber driver, again, probably not looking at a THC product. Have they used cannabis before? Not necessarily a problem. It might be useful to know what they've used, or more correctly, what effect what they've used has had. So GT is a 76-year-old female patient with osteoarthritis of the back, neck, both hips and knees. She's got COPD, got other problems as well. Parkinson's, ischemic heart disease, fairly typical elderly patient. She's been on, this is her current medications, Pentadol for pain, paracetamol, Parkinson's meds, blood pressure meds. So again, she's got stable heart disease, so medicinal cannabis can be considered. She's been on short and long-acting oxycodone. She's been on paracetamol and codeine, tramadol, anti-inflammatory. She's had both hips replaced. Spinal injections. She's had physio, chiro. Again, this is a very stereotypical case, and these are the sort of people you'll be seeing if you're going down this path. Got acceptable renal and kidney function and stable ischemic heart disease. So she's an ideal candidate for balanced formulation. Why equal parts? The data and evidence does suggest that it is the most likely to help with chronic pain. In different circumstances, we might look at CBD dominant, maybe in some circumstances CBD alone, Not saying it wouldn't help, but this one is more likely to. We're starting at a low dose, again, 2.5 milligrams. So again, I think I already answered that question, why 1010? It's the logical start place, but there might be reasons that you don't. But your beginning point in choosing a product is what would be the most suitable for the clinical situation, and then you move outwards from there. So after a couple of weeks, pain's a bit better. It's not gone, we wouldn't expect it to. She's sleeping better. We've got it up to 0.5 mils. We're wanting to nudge it up a little bit, keeping in mind this remains a very low dose, but if it's helping, that's great. So increasing it to 0.75 and then 1 mil, which is 10 milligrams of THC and CBD per day. And that can be either in divided doses or just at night. It's personal patient preference. 6 weeks later, the pain is less. She's happier, the family's happier, she's sleeping better and has an improved quality of life. And that is really the key determinant of all this. People are just having a better day. BD is a 36-year-old male with long-standing, we're talking over 15 years, anxiety, social phobia, and insomnia. He's been on a long list of SSRIs. He's been on various benzos, been on quetiapine, he's had other atypical antipsychotics. He's been through counsellors, he's done hypnosis, and after all of that, he's still got his symptoms and he struggles to leave the house by himself, so his father comes with him. So he's a good candidate for CBD dominant. Now, we could use CBD alone in anxiety in a case like this, and it'd be quite reasonable, given that he's got insomnia as well. That little bit of THC is going to help with his sleep. And again, starting at a relatively low dose of 0.5 mil and increasing to 1 mil after a week. 2 weeks later, he's sleeping better, and often sleep is the first indicator that people are getting a response. He's a little bit less anxious. 6 weeks later, his words, the best he's been in years. The father, and in his words, is amazed at the improvement. This is a guy who's had to psych himself up for 20 to 30 minutes to leave the house. And a couple of years later, he's still on 1.75 mils daily and he's got a part-time job. JT is a really interesting case, in my opinion at least. 17-year-old. Severe anxiety, autism spectrum, behavioural issues. Now, kids like this, I suppose 17 is not a kid, but you know, people in this sort of cohort often not only have they been on lots of medications, but they got a long list of diagnoses. And he's seen paediatricians, psychiatrists, OTs, psychologists, you know, some alternative, in inverted commas, practitioners. I don't like the term, it does get used. And yeah, he's been on a long list of medications. And keeping in mind, all of these are, in a lot of instances, well, no, not all, but a lot of them are also off-label. And his parents are desperate, which is probably not surprising. And he's sitting in the consulting room with his headphones on, he's got ASD, pretty disinterested with the world around him. Perfect candidate for straight CBD, including the fact that he's under 18, and that for anxiety symptoms, the CBD is the go-to. 2 weeks later, he's sleeping better and he's catching the bus to school. Catching the bus to school doesn't seem like a big deal, but for him it was. Over the subsequent months, he's going to school parties, which he didn't do. His school attendance has improved. He's coped with masks. This was through the COVID response period. And he coped with masks, which his parents said he would not have been able to do, which in turn would have meant he couldn't have gone to school. And 3 years later, he's still on around about 1.5 mil per day, or 75 milligrams of CBD. And his life has been significantly transformed. In cases like this, you're not only helping the individual, but, and obviously that's the person we're treating, but there's benefits to family, including parents and siblings, to people at school, to the teachers. The ripple through effects are significant when one can improve the life of an individual like JT. All right, at this point, I will hand over to Barb.
Sliding or moving? Cool.
Yeah.
So it's that awkward moment when we switch seats. Hi there, everyone. Thanks so much for joining us. My name is Barb Fullerton, and I am Head of Education here at Little Green Pharma. Just wanted to show you a little bit about who we are as a company. We've been around for quite a long time in cannabis years, maybe not so long in other companies out there, but since 2018, we were one of the first companies in Australia to get our license to grow medical cannabis, and we do that here in Western Australia, as well as at our facility we purchased in Denmark in 2021. We were also the first company to produce a locally grown medical cannabis oil here in Australia, and the first to export into Europe for that same product. We have over 1,500 prescribers and tens of thousands of patients. We're very focused on the patient accessibility in terms of helping you, the prescriber, access medical cannabis for them, but also in terms of, I guess, the pharmacy and making that process as simple as possible. Another example is if a patient drops a bottle, we'll replace it, or if has any issues, we go out of our way to make sure that that patient has a great experience. That's just part of our core values, and we have a great customer care team that looks after patients and pharmacies that contact us. We also have a strong commitment to research, which we have since day one, and I'll take you through some of those studies. Another differentiator with us is since day one, we've had a compassionate access program, which allows doctors to access discounted medication for their patients. So if you have a concession card holder or healthcare card holder, they get a 10% discount at pharmacy, which is great for them. But if you have those undergoing financial difficulty or aren't sure, we can offer a 50% discount, and for some patients, medication at no cost. So some of the studies we've been doing, patients coming off those studies that were previously accessing medication at no cost, we continue to support them, and we have families with kids who are unable to or have been unable to afford medical cannabis that we've supported for years. And I worked it out at the beginning of the year. We usually give away around $1 million worth of product through our compassionate access program, which is pretty cool. This is a photo of our Danish facility over here. I always get the numbers wrong, but it's about 20 times bigger, Joe, than our facility here in WA. At least it's huge. And so the difference between the two facilities is our facility here in Western Australia is completely indoor facility. So that's everything is controlled with that plant, the lighting, the heat, humidity, nutrients. Whereas our facility in Europe, which is right next to Germany, is a glass house. So still that same level of control, but because it's bigger, we do harness the sun's rays when they're available in Denmark, which means it reduces our power costs, but it means there's a little tiny bit more variability with the different batches. And that's just due to the size. And glass house is a lot more common than this full indoor grow. This indoor grow is more boutique from a flower perspective. So how are the oils made? I'm glad you asked. So we start with a cloning from mother plants. So what we do is take small cuttings from plants that we clone. So the genetics that we've had, for example, in WA of our Desert Flame, which is the first flower we released, are the same genetics than when we first started. So each time we take a cutting from that plant, those clones take up to about 2 weeks to develop roots. They're then transplanted into a different room where the lighting, humidity, temperature, water, nutrients, all those things I said before are controlled. And that growth cycle, depending on the cultivar, is anywhere from 10 to 14 weeks. From there, you go to the drying room, which again takes up to 7 days. That's when we send it off for our first testing. So the difference between medical cannabis and, say, street cannabis or someone who's getting it from their neighbor is we send it. Australia actually has the strictest growing standards. So even though we grow in this indoor facility, we still are testing for things like pesticides, ash, aflatoxins, and foreign matters, heavy metals, things like that. If, for example, one of your patients is getting it from their neighbors who's growing it organically in their backyard, the neighbor before that may have had pesticides, which will then be in that plant. So cannabis is very absorbent. So just something to keep in mind for people who are accessing it on the black market. So once that cannabis comes back, if we're making an oil, we then soak the cannabis. There's a couple of different ways you can extract the resin. It's CO2, ethanol. And what we're trying to do there is preserve as much of that plant as we can. At our facility here in Western Australia, we use ethanol extraction. So we actually soak the flowers, which dissolves the resin. And then that ethanol is heated off and we're left with the resin. That's sent off again for testing. And then we have the concentration of the THC and the CBD resins that we're using. And we use those to mix to make oils. And it's when the final product is literally just the resin and the MCT oil. So that's the oil process. The flower is very similar up into the drying stage. Once it reaches that drying stage, it goes to one of my favorite terms, a bucking, where what they're doing is pulling the flower off the stem. So you're left with just the flower. From there, it then goes into a burping phase, and these are some of the things that we're changing in our facility down south at the moment. But that burping allows a more even dryness from the middle of the bud to the outside, which then leads to a better medical or therapeutic experience when they are vaping it. That happens over a couple of days. It then goes from there to inspection and trimming, which is we use both hand and machine trimming at our facility, and then goes into packing. So it's not as easy as just pulling it off those flowers off the bud and putting them in this container over here. It's quite a laborious process. I did mention that LGP has been very invested in research from the very beginning. We have the Global Quest Initiative, this study, which we're running now, and I'll talk a little bit about that in a minute. So that's Quality of Life and Health Economic Study. So the Global Quest Initiative was a second iteration to the Quest Initiative, which again was a quality of life study. The second one has a little bit more of a focus on health economics. The first Quest Initiative paper, the 12-month data is due to be released very soon. I think it's been accepted. We're just waiting to see which publication it goes in or which month it's getting published. But that's really positive, and that's across our range of oil and flower. There was the CARE New South Wales trial, which is one of the ones that I spoke about, which is wrapping up and patients are getting moved over to our compassionate access program. That was an open label study looking at patients with advanced cancer for symptom control. And again, it's had some really positive results anecdotally, but that's yet to be written up. We've worked closely with the Mater in Queensland on MedCan 2 and MedCan 3. Both of those studies are looking at different ratios of cannabis oil in patients with advanced cancer. And I think it was MedCan 2, the abstract was presented at ASCO in June or July with, it was really positive. So again, we're waiting for that full publication, which should happen in the next month or two. We're also doing another study looking at our CBD dominant oils and the presence of THC in blood, urine, and saliva to see how that's metabolized in our CBD dominant products. There is another study which I think is just wrapping up as well, using our 1010 oil in patients with fibromyalgia. Again, anecdotally, even though that was double-blind placebo control, seems to have had some good results. There's another study looking at chronic pain, and those patients received our 1010 and showed that study has been published and showed statistically significant benefits in our 1010 oil. And the cool thing about that study is that that's patients that have been on, like Joe mentioned, a number of other pain medications, and the pain was not controlled. So it was cool that we were able to get such a great result with our 1010 oil. And there's yet more studies, but this is one last one I'll talk about, which is looking at patients in France and controlling symptoms from HIV. So a little bit more about the Global Quest Initiative, what's involved. That's with Curtin University. If you are interested in being involved in that study, enrolling patients, it doesn't take long to enroll in the study and be able to enroll patients. Patients that you then would want to enroll in the study, it takes about 5 minutes to go through the survey to ensure they're eligible, and then patients are required to fill in questionnaires monthly, I think initially weekly and then monthly over a 12-month period. The benefit to patients is that they get subsidized medication. The benefit to you, the prescriber, you're contributing to research and learning more about medical cannabis with your patients. So if you are interested in being a part of that, please do reach out. We have a number of resources, and I recommend you go to littlegreenpharma.com to our medical portal and sign up because there's webinars like this one that you can access, as well as other ones we've done on special conditions or specific conditions. And there's also a bazillion resources like these. So there's guides to certain conditions and what oil or flower or vape product you want to use. Again, product selection guides of what to use for what conditions, consent form templates, which we do encourage any new prescriber or any current prescribers to use for patients so they understand that medical cannabis, how it's accessed, what they can and can't do if they're driving, etc. Titration tear-off pads, vaping guides. So there's a bazillion resources. If there's something that you would love that we don't have, that's great. We can create it for you. So just let us know. But yeah, encourage you to go on and look at those resources. And they're available to either download or we can get hard copies sent to you as well. So as a company that's been around for the last 7 years, we've developed more recently, actually, a much wider range of product. Originally, we were just very focused on our oils. That flower market has grown significantly here in Australia, and that's a lot of patients that were probably accessing it through the black market that are now accessing it medicinally. So we have a great range of flower products, our oils, which are the longer acting ones, as well as vape cartridges. So what those are is it's a distillate resin, so no additives like you would get with the nicotine vapes. And it's a way that if a patient is experiencing breakthrough symptoms and they don't want to mess around with flower, maybe they've never used that recreationally, it's a much cleaner way for them to access a short-acting medication. Another important note that you may or may not be aware of is there's a lot of private health insurers that are reimbursing patients with extras covered for medical cannabis up to a certain amount. So with HIF, who's an insurer here in Western Australia, they also, patients that have their extras covered also get an additional rebate for LGP products. So worth looking into if you do have patients with private health insurance wanting to access medical cannabis. We have a national team of MSLs. So in WA, Queensland, and New South Wales, we're recruiting. If you know anyone, let us know. But yeah, so there's someone there that can literally come and see you and hold your hand. And we're also happy to help you here at head office. And I think we're doing pretty good for time. So you've heard enough from Joe and I. Now it's time for us to hear from you. So, oh, that's a good question to come out with. So what might be the current and future challenges for medical cannabis in Australia? Where do you start, Joe?
Gee. Well, I think the initial challenge, like if we're sitting here 6 years ago, there was almost this view that there's no role for cannabis. It shouldn't be used. People didn't want to know it or know about it or touch it. And we're now at a stage where an increasing number of doctors, and obviously, you know, you're on this call, you're interested. Not every doctor is interested to prescribe. I don't think they need to be, but increasingly they are open to saying, yes, this may well help you, you being a patient, and referring to people who are. So I think that sort of challenge is not completely overcome, but it's getting there. Look, I think there is, as with all new industries, probably going to need to be a little bit of a shakeout. There are a few, you know, there's a couple of outfits that I'm trying to think how to
Cowboys.
I was trying to avoid that word. But yeah, look, there are probably a few cowboys out there, and they need to be reined in. I think the regulators, as is often the case in this country, tends to sort of wait for problems to occur. They're never very proactive. And then one of the risks is that they try to sort of lower the balloon because they want to get rid of a few cowboys, but manage to make life difficult for others. We'll wait and see. There was a meeting of 20-something organisations in February who ended up deciding that they'll meet again at some stage, but at some point they will. Look, I think the challenge is going to be getting a more logical regulatory framework. It's a bit of a mishmash at the moment. Getting some level of standardisation across the country, which is always a problem in a federated system. And probably the biggest ongoing challenge, but this is the one where we're probably furthest advanced, is getting a level playing field in terms of people shouldn't drive if they're impaired, but if they are not impaired, they're not impaired, and they shouldn't be discriminated against because they're taking cannabis versus another medication.
Yeah, no, that's a big one. On that, so where do you with patients with driving, how do you have that conversation with your patients? I know you touched upon it a little bit, but
look, essentially, they need to know the laws as they stand in their particular jurisdiction, and my suggestion is that they need to sign a form that confirms that they understand it, which basically says if they do get caught and it is in their system, that they may face prosecution. And not necessarily, but they might do. Some people on that basis will not want a product that has THC. They're not prepared to take any risk. Realistically, a large number of people are prepared to and have and do and continue to run the gauntlet, and the numbers who seem to get caught is remarkably small. Work done from the University of Sydney, it was probably something in 2021, suggested that anywhere between 3 and 8 hours after an oral dose, that it might not be detectable on roadside testing. That is very different to urine testing, where it may be detectable for days and possibly weeks afterwards, depending upon dose and how frequently it's taken. Fair to say that in a medicinal dose, probably gets out of people's systems quicker than when used recreationally because they're just not taken quite as much. But ultimately, you have to be straight up with people, tell them this is the situation and circumstance, and then they need to make the decision, as in everything in medicine, in a fully informed model. The police don't tend to do, and I was told this by people who, I won't quote, but who know about this from the inside, that typically the police will not do random drug tests on people unless A, they blow zero and give the very strong impression of being on something, or B, they look like they're criminals or very suspicious. And certainly in my personal experience, that's a very minuscule proportion of people are on medicinal cannabis. And why is that the case with the police? It costs them money. So rather than raising money, it costs them money. We'll leave it at that.
In terms of, I guess, initiating a patient on medical cannabis, what do you do with the drug that they're currently on?
So really important point. So thanks for that question. Day one, you leave everything alone. The medicinal cannabis is in addition to, not instead of, current medications. The starting point is that they're not getting adequate control, and so therefore we're adding it in. Now, at some point down the track, it may be that if they're getting a good response, that you can reduce and in some instances stop other medications. But that's not an end in itself. And if you stop other medications on day one, people might actually get worse, not better. So if they're getting a good response, and some people are very keen to wean off variably opiates and the pregabalin, in my experience, and some people it's fine for, but a lot of people seem to want to get off it, and then they can reduce their dosages slowly, and that reduction can be as far as they maintain good symptom control. The aim of treatment with medicinal cannabis is improved symptoms and quality of life. If in addition to that one can reduce and or stop other medications, great. If people need all of the above to get improved symptom control, then that's great as well.
Right, thanks, Joe. Someone's made the observation that it seems that the dried herb or the flower is getting prescribed a lot more than oils. What would you recommend starting a patient on, and why? And why is there that trend?
Why is there that trend? If we were doing this webinar, which we did, we were doing this webinar in 2020, I think it was roughly 85–90% of prescriptions were oral, and something like 10% were herb and
I don't even think there was flower. Yeah.
Maybe 2021.
Yeah.
It really was. And now we're at 50–50, and the trend is probably to a predominant flower. Well, I think as with everything in life and in medicine, there are trends and there are more flower products available. So there's a much, much bigger range of flower products than there are oral products. I think we've also seen, and this is probably one of the key drivers of it, we've seen a lot of people come out of the shadows, in inverted commas, So these are people who the term coined is med rec. It's not a great term, it's the one that's used. But basically, these people have been using cannabis illicitly, so they're in the recreational market, but they're not using it recreationally. They're not using it to get high. They're using it to treat their symptoms. And those symptoms are variably chronic pain, sleep, anxiety. And they're doing that because the other medications haven't helped them. So we're increasingly finding, especially with the price of the flower products having come down, that a lot of these people are wanting to move into the legal market. They're familiar with flower, they're quite happy with it, they're familiar with it, and that tends to be their preference. And personally, I don't have a strong view either way. I think for people who've not used cannabis before, I typically always start oral. You might think about a vape cart. People aren't familiar, probably not going to be that interested to buy a vaporizer device and start fiddling around with dried herb. Look, it's not difficult, but they're probably not going to want to. But because of that cohort that's come into the legal market, I suspect they are driving the increase in flower sales. And there's no right or wrong in terms of which one you should use. It's very much to the individual, what symptoms you're trying to control, what is their preference, what are their other circumstances, and then a decision can be made.
And I guess one thing I'll add to that as well is there are, so particularly for those patients we call them med rec patients, so medical recreation patients that may have been accessing it on the black market, now moving to medical, might have a really high tolerance. So there is an argument to add an oil in and really get the management of their condition under control. So can you just comment on that?
Yeah, look, and this is where it is important as a prescriber that you do remain in charge.
Yeah.
And that's been one of the allegations about some of the, I'll use the word, some of the cowboy outfits that they will prescribe. Yeah, look, why not? We've jumped feet. That's it's the same in medicine. There'll always be a few out there. It's always the case with everything. But maybe prescribing high doses of flower beyond what might be recommended or therapeutic or indicated. And for those patients, if they do come in to see you, then it's very, very much about saying, this is what I think is appropriate for your needs. And because oral as we saw on the slide, lasts longer in their system, that giving them a baseline orally may be beneficial, so they're not relying on the shorter acting form in inhaled, and that in turn can reduce their dosages over time. But very much as a prescriber, it is about, as with any medication, it's about setting, this is the dose, this is what you're taking. You can not issue repeats if you want to do that, or you can issue them with a time frame of when a repeat can be activated. So for example, if there is a 10-gram type of flower and you want the person to have 1 gram per day, keeping in mind it's 1 gram of flower, not 1 gram of THC, and that's 10 grams, then you can set that the minimum time frame before repeat can be filled is 10 days. It can be 7 days, it can be 14 days, whatever it is. So really keeping that control the same as you can and would otherwise and should do with any other, particularly S8 or psychoactive medication.
And there is some, just back to adding an oil in to help reduce overall flower usage for those patients is there is some good evidence that by doing that, they were able to reduce it substantially, which is a win-win, right? Because they're able to control their symptoms easier. It's better for their back pocket. And so on and so forth.
And better control of symptoms if they're having a formulation with a longer duration of action.
Yeah. A couple of questions I'll jump through that I can answer around when medical cannabis might be over the counter in pharmacy. Obviously, that would be CBD. We're still waiting on the studies. There's been a number of studies that have looked into different conditions that haven't had the evidence needed to support that. So
very difficult and very expensive to do these studies. And companies in the medicinal cannabis space really don't have the pockets of some other pharmaceutical
big
companies.
Pharma. So that's a good question. Vaporization devices. So vape devices, there was a crackdown recently on how patients can access that. There are a number of pharmacies that have, I guess, the license or the way to import them directly. We can help you out with that if you have patients looking for that. And if you as a pharmacy want to do that, you can also get in touch and we can talk to you about that. Question for you, oh, this is actually an interesting one about patients between the ages of 18 and 25. APRA is not crazy about using THC necessarily in that cohort. How do you manage that?
Look, above 18, THC can be used. As with anything, there needs to be some clinical justification. So I don't think you'd typically be going, and certainly not starting with a high formulation. APRA tends to react to complaints, and most of the complaints they've got typically been more about people not getting enough rather than being prescribed too much. Those have been most of the complaints. As a setter of standards, it's not of itself typically expressing clinical views as to what can and can't be prescribed. State health departments do, and in New South Wales, there has been a crackdown from their pharmacy services unit on doctors who were deemed to be prescribing doses of THC that were deemed to be too high or inappropriate. I'm not going to comment on any of those cases. I'm not familiar with them. But that would be the same principle as with opiates, with benzodiazepines. All of these things are monitored. The HIC is not going to get involved here because it's non-PBS, so they're not interested. It doesn't cost them anything. But it's more the state health departments that may be looking at prescribing. And look, it's not difficult. Look, and I've been at this for 6 years now. It's not difficult to stay within the realms of what is quite justifiable and clinically appropriate. It really isn't. That there are a few cowboys out there getting pinged is arguably a good thing, because for everybody else who's going down the right path and prescribing in a clinically justifiable, appropriate and beneficial way to their patients, then no, none of the authorities have any particular interest in that, and neither should they.
I'm going to two more questions after I realize we're a little bit over time. One is, have you had any patients with suspected cannabis use disorder? And if so, how would you manage that?
Look, personally, I haven't. Although there's one guy who I suppose I had suspicions about, and it's essentially a my way or highway scenario.
Fair enough, yeah.
You want to use these high doses, it ain't happening. Certainly not. I'm not going down that path with you. If we want to control your symptoms, then we're going to have to bring your doses down to these levels. And rightly or wrongly, that may mean them needing to go through not so much a withdrawal, I suppose, but an adjustment phase and period. This comes back to setting the agenda as the prescriber. Look, I suppose to round out the previous question, I went off on a bit of a tangent. 18 to 25, if the benefits if the benefits are justifiable, then THC is not absolutely contraindicated, but you just need to be quite satisfied that the clinical indication is there and that the benefits outweigh the harms. But look, under 18, different story. Above 18, individual clinical assessments. And
with those patients that you might be worried about using too much, do you use real-time prescription monitoring? I know that's
that's an issue. Ordinarily, different states have different requirements.
Yeah,
it comes up with a green light. In some states, you can proceed. If it comes up with a red light, you need to click into the website. I think in Victoria, even if it's a green light, you still have to log in. I think Queensland might be similar. I can't speak for every jurisdiction. That's a slightly separate issue. That's about doctor shoppers and people who may be using too many medications in general. That's different to an age-specific issue. Yeah.
And then last question, which is in more a tactical one, is one of the pharmacies has a patient getting an oil, but it's quite thick. They're not able to get it into the syringe. So that's very unusual. I know with us, we have a hole, and it's, because it's mixed with MCT, it's very easy to get out. But any suggestions there, Joe?
To get oil out of a bottle if it's too thick.
Thick one, yeah. Warm it up.
Yeah.
Use an LGP one because they're easy.
So maybe if the product isn't suitable for whatever reason, the individual, maybe they need to change product. probably can't give any specific
Yeah,
advice
I
on
haven't heard that.
how to get something out of it. Maybe give it a bit of a shake.
Yeah.
Maybe you have to take the plunger out and tip it into a teaspoon and then draw it out. There's some workarounds. It's going to be a little bit messy.
Yeah.
Maybe pour it into a different bottle with a what. But if it doesn't get into the syringe,
Yeah,
I think I'd
interesting.
maybe be taking that back to the pharmacy and or supplier, because the whole idea is that they do get drawn up through a syringe, and if they don't, then there actually might be an issue or problem with that bottle or that batch. Again, I'm not saying there is a reason, but it'd be worth asking the question.
Awesome. We're going to
All
leave it
right,
at that.
yeah, I think we're a bit over time, but I think just about everybody stayed with us, so thanks very much for that. You will get a link to the presentation in the next few days or so for all the registrants. Anybody wants to watch some of it again or pause at a particular point. But for now, thank you to everybody for being on the webinar this evening. Thanks for your questions and your engagement. Barb, thanks as always for co-presenting. And to everybody out there, enjoy the rest of your Tuesday evening.